Good morning. On behalf of the Border Solutions Alliance and the West Big Data Hub, thank you for joining us today for our lightning talk with Leslie Ray, the Senior Epidemiologist for the County of San Diego Health and Human Services Agency. This morning, Leslie will spend about 15 minutes providing us with an introduction to COVID-19 data in California, and then we'll have a few minutes of moderated questions. Leslie, I'll go ahead and turn the floor over to you.
Thank you so much. I really appreciate the opportunity to talk with you and talk about data. What I want to talk about is the public health data that we have available around COVID-19 at a variety of levels. But there are a few basic things that we need to establish for people who aren't used to working with public health data. We use public health data for a variety of issues, including assessing and monitoring health problems, understanding the extent of the problem, identifying target populations, and by that I mean those populations that have either an extremely high likelihood or risk of developing a particular disease or health problem. We use this for diagnosing and investigating or determining different hazards that are in the midst, much like disease investigations. We also use this to implement and evaluate our programs, to develop our policies, and to establish priorities. Data is used throughout public health. It is essential, and it is probably the single most important thing that we use in public health to help us look at the health of the entire population. So basically, data collection is just gathering and measuring information, okay? We use basically things like data repositories or databases, and often, particularly in population health, what we'll do is take that information and aggregate it on certain variables so that we're not talking about a single individual, we're talking about a group of people that share common characteristics. Now, we collect data from doing in-person interviews, questionnaires or surveys. We'll do observational data, we do focus groups, but we also do a lot of documents and records. So health data, hospital discharge data, death data, birth data, all of that kind of information comes from what we call secondary sources. And we use a lot of that to describe the health of a population around or in looking at certain diseases or certain health issues or health behaviors. So for COVID-19, we collect and present a variety of data. This is actually off of the county's website, and we produce this chart daily. And what it is the summary of the COVID-19 positive cases and by various characteristics. So as you can see, in San Diego County, we're coming up on 40,000 cases. What's important to look at in this chart is we have three different ways of relaying that data. We have counts, which are the number of cases. So in 0 to 9-year-olds, we've had 1,226 positive cases of COVID. Most people think COVID is only happening to older adults. That is not the case. In fact, our largest group is 20 to 29-year-olds. We've had almost 10,000 20 to 29-year-olds, 25% of our cases. So what I want you to see is there's a count, which is how many. There's a percentage, which is how many of the whole. And then there's a rate, which is what is the risk of that group or the likelihood of someone in that particular group having the disease. And a rate is really important, and I'll talk a bit about that in the next slide, I think. But What a rate does is tell us if all populations were the same, what is your likelihood of having it, or the likelihood of someone in that population having it. So it's really useful for us to identify at-risk groups or groups that are having a disproportionate or an unequitable share of disease. And if you look at just this age distribution, look at the rate column, you'll see that the highest rate of disease is actually the 20 to 29-year-olds. Most people would think it would be in the 80 plus. Even though when we look at who is hospitalized or who is dying because of COVID, you'll see much higher numbers in those older adults. We cannot forget that this disease is impacting our young adults disproportionately. In fact, 25% of our cases are among 20 to 29-year-olds. A lot of that has to do with behavior. As you get older and your risk of contracting the disease is more is higher, then you're going to be more careful. You're going to pay attention to social distancing, to hand washing, to wearing a mask. Whereas someone in their 20s, we call the 20s the invincible decade, and they tend to not think of themselves as being susceptible to severe illness or things like that. They also were much more social and more likely to interact and forget to do some of the things that we are strongly recommending to prevent disease. Disease cases actually are slightly higher in women, although deaths tend to be higher among men. Let's see. So the difference between numbers tell you how many positive cases there were. The percentages tell you the proportion of the whole. And then the rates tell you how many per a given population and allow you to compare either over time or between populations. And what that means is by standardizing the population to 100,000, what we're doing is saying if each group had 100,000 people, this is what the rate would be, or the amount of disease we would expect. We know that all groups do not have 100,000 people in them. So the idea is what you're doing is creating a standard measure that allows you to look at the likelihood or the risk between different groups and do that kind of comparison. You cannot compare all data, so you have to be careful. The white population had a higher number of cases, but a lower rate per population. That's because there are more whites in San Diego County than Native Hawaiian Pacific Islander. But if you look at, there are very few cases among Native Hawaiian or Pacific Islanders, but they have a very high rate. So it depends which number you choose to look at, depends on what the purpose is. If you want to compare whites and Native, the risk of contracting COVID between whites and Native Hawaiians, you would use the rate. If you want to look at where do we need the most resources in terms of tests or supplies, you would look at the count. If you want to understand how the number of cases varies between the groups, then you would look at the percent. So why do we break this out into smaller groups? And the reason is we're trying to understand the extent of the problem. It lets us focus on health equity. And that means if we can assess the differences it tells us where we can focus and where we can look at what are true disparities between who is exposed to disease and who is not. So what are the differences in the populations? Now, health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving the potential. Health equity does not mean, it is not the same thing as health equality. Okay, equality on the left-hand figure there is everyone has the same level of support, but that doesn't mean everyone can reach the apple. So health equity, what we look at is those communities or those groups that may need more support so that everybody can reach the apple. So where do you find more data than you ever wanted to know about COVID? If you're looking at international data, because this is a pandemic, that means it's worldwide, you want to go to the World Health Organization, and you can go to this website here, and that will give you a lot of information on how the disease is moving throughout populations in different countries. That's really important because one of the things that we looked at early on in San Diego was we started comparing countries like South Korea, Japan, and then Italy, and into some of the European countries. The reason we did that was nobody knew what worked. If you remember last spring, we knew very little about the virus. And so what we did was we looked at countries where it had already been for a couple of months to see what was working for them and what wasn't. So international data is very important in terms of providing us with some basis for how we should perhaps go, or things that we don't want to do. So you learn both ways from looking at other places who were more advanced in their disease. Nationally, you can go to the COVID site at Centers for Disease Control, and they have numbers. There's also a couple of universities, Johns Hopkins in particular, maintains dashboards that are really useful for comparing COVID between states and between other countries. For California, the COVID-19 data, information, and models, there are two different websites. The cdph.ca.gov is the general information and data for every county in California. It's also the governor's guidance and the rules. It is really kind of your one-stop shop for information about COVID in California. CalCat is a tool that the public health has put together, state public health has put together to look at modeling, to give us some sense of where we are going to be. Now, if you're interested in data modeling and interested in trying to project or predict the course of the disease in a county or a group of counties or in the state, go to the CalCat website. It's an open website. You can also download a great deal of data on different counties there. And this is all public data, so anyone can go in and get it. The idea is they've looked at about 16 different models of the disease that have been developed both locally and also at universities and around the country, and also a couple in Europe. What this will give you is a sense of where different models project this disease is going and where our epidemic will go. For San Diego, the best source and best starting point is coronavirus-sd.com. You'll find all of the data tables, plus you'll find information on different activities that are different restrictions, all of the local information. Plus, we present daily the national, state, and actually the international, national, state, and local data on the case rate for the disease. And really a good, well-rounded site with lots of information, and also lots of information on what's going on locally. Now, lastly, at my group's website, Community Health Statistics, you'll find a whole bunch of information on demographics. Demographics are very important because in order to calculate rates or to identify groups at greater risk, you need to know how many people are in that population. In addition, if you are looking at what are the underlying conditions, all of the data on how many people in each community have these underlying conditions is available on the sdhealthstatistics.com website. So a lot of information is available to you. A lot of it is downloadable in different formats. And we are really looking at trying to make as much information available as possible. The one caveat is we don't release individual level information to protect an individual's privacy. So that is the data that's available locally for COVID-19. You have questions?
Thank you, Leslie, very much for your presentation. I have two questions that I'd like to ask. The first is regarding health equity. And so I'd like to know if in what ways has this current pandemic shined a spotlight on health equity in our community? Have there been surprises for you or things that we've learned from the differences in how different parts of our community are experiencing the pandemic?
Yes, one of the things that was surprising, we've been monitoring health by health differences by age, by gender, by race, ethnicity, by geography, and by socioeconomic status for quite a few years now. That's been a real push and concern of our public health officer, Dr. Wooten. And when we look at that, we tend to see usually stronger health among our Hispanic population. So when I'm seeing rates or cases double what I would expect in relationship to their proportion of the population, and when I see that throughout the county, not just in South Bay, we've looked at what are the other factors that might be contributing to this disparity. And there are a couple things that come to mind. One is we have a higher proportion of individuals who are engaged in what would be called essential work and in support services in our healthcare system. So these are not doctors and nurses, but these are people who provide supportive services in hospitals or in clinics. And so while the doctors and nurses would have direct patient contact, supportive services would not necessarily get the PPE because they wouldn't be necessarily in patient contact. And what we've come to learn over the last month or so is that this virus is in fact airborne. So that provides a greater risk for people who normally were thought to be okay when we thought it was just on surfaces, or that you would get it from close contact with an infected individual. Also among our Hispanic population, culturally, there tends to be a higher a higher proportion of multi-generational households, which means basically if you have kids, parents, and grandparents in the same household, the grandparents by their age are most susceptible to a more severe form of the disease if they contract it. You have parents who are going out and doing essential work, so they're going out and then coming back into the community, into the household. And then you have kids, and as schools begin to start up, we're very concerned about infection and everything among, and bringing that home, an asymptomatic infection among kids. We also looked at income to see who would be economically at risk of homelessness, food insecurity, and things like that by this pandemic. And where could we step in to try and make sure that people did not suffer disproportionately as much as we possibly can. There's been an awful lot of testing and a lot of health resources that have gone into communities with higher Hispanic population. The other one that surprised me that has popped up is in our Native Hawaiian Pacific Islander groups. It's a small group by comparison to some of our other demographics, but they have a much higher case rate. And it's interesting because they also have a much higher rate of smoking, whereas our Hispanic population tends to have a lower than expected rate of smokers. And we know that this is a lung disease. However, we also know it's diabetes, and diabetes is higher among our Hispanics. So there are all kinds of threads to this puzzle. And like I said, it's a novel virus, a new disease, and we're learning new things every day. But we keep looking at all of the different factors that may contribute.
My second question is about trends. And since there's so much data available, people have access to understanding trends as things get better and things get worse. Do you have any hypotheses, or do public health authorities have hypotheses about what's been driving the improvement in trends recently in San Diego?
Well, one of the things we know is that, and you can look at trend graphs if you go to the San Diego, COVID coronavirus-SD website. You can actually see the trends and see the trends over time. And we were actually doing really, really well when we were in that tight lockdown in the spring. And our rates stayed much lower. Our hospitals did not get overwhelmed. Everyone, all of us who had been predicting how bad it could get, it didn't, because everyone took this very seriously. And we have a certain level of fatigue with all of these restrictions on people's movements. We have financial concerns coming from individuals and coming from businesses. And so there was a lot of reason to allow businesses to open up sooner. And as soon as we opened up a number of our businesses, and as soon as we were one of the few areas that had their beaches open, we got a lot of tourists in too. And so we got people in from communities that had high rates of COVID infection coming to visit San Diego and not necessarily being aware of masking or complying with masking. Opening bars is an issue because people tend to be less compliant with, or less careful with wearing masks and with keeping social distancing when you add social behavior and alcohol into the mix. When we closed the bars within 7 to 14 days is the time period you look at, the rates went back down again. And that's one of the reasons and rationales behind being very careful in reopening now. And The governor's reopening plan is really looking at doing this slowly and doing this right, because we can't afford to do another open up, have rampant infection, and then have to close back down again. So we're going to open more slowly now and pay attention to changes as we begin opening up different sectors, and making sure that we're on those right away and can make the necessary changes.
Thank you, Leslie. Thank you for your presentation and for your comments. And thank you very much for all of the work that you're doing to help keep our community safe and healthy. Appreciate your time today.
Thank you so much. Thank you for having me.